Hello and welcome. We hope we find you today socially distanced and in good spirits. My name is Chris Lytle, Deputy Director of Systems for Action. Thanks for joining us for our Research in Progress webinar. Systems for Action is a signature research program of the Robert Wood Johnson Foundation, and we support studies across the country generating novel models of integration between healthcare, public health, and social service systems, creating an evidence base for the systems level change necessary to improve population health and promote health equity. If you'd like to learn more about our projects and how we look to put this evidence into action, check out our our website, systemsforaction.org, and follow us on Twitter. Today we'll hear from a project that started back in 2017, implementing the Tasina Luta Public Health Foundation for Cheyenne River. So we'll be hearing presentation from David Washburn, followed by commentary from Carpenter. And if you have any questions, feel free to add those to our Q&A box. Our team here at S4A will be managing that. After the commentary, hopefully we'll have some time reserved to answer those questions, or at least have our presenters answer those questions. So without further ado, I'd like to introduce our presenter, David Washburn. He's an assistant professor in the Department of Health Policy and Management at the Texas A&M School of Public Health. If you'd like to learn more about his background, these slides will be included in an email afterwards, and will also be uploaded to the website. Next slide, please. All right, we'll be hearing commentary, like I mentioned before, from Carpenter, Assistant Director of both the Office of Special Programs and Global Health in the USA Center for Rural Public Health Preparedness at the Texas A&M School of Public Health. So without further ado, I will hand over the controls to David Washburn. Thank you.
Thank you, Chris. I think I have control of the screen now. Let's see here. All right, yep. Let's just go back. There's a slight delay, it seems. Thank you, everybody, for joining us today. It's a privilege to be speaking with you. Hopefully, as Chris mentioned, you're all able to stay socially distanced as appropriate, and thinking about those folks who are perhaps less fortunate and less able to do that because of employment requirements or other issues that they may face. But hopefully we're all staying as safe as we possibly can. Today I'll be talking about a public health program that was a locally designed initiative in the Cheyenne River Sioux Tribe Reservation in central South Dakota. The plan is called the Tasina Luta, and it has 4 pillars. These pillars were developed by local tribe members and were an attempt to increase engagement with the existing healthcare system, really encourage people to access care when they needed it in a timely manner in a place where that had not been happening for many, many years. The 4 pillars are as follows. It's really trying to encourage an annual health review for every member of the tribe, actually for every person living on the reservation, to implement health-wise handbooks, which is thought to be a document that, or a small book that people could have in their homes in this very rural setting that would help them with minor health issues. To also implement a 24-hour Ask a Nurse hotline. So in this part of central South Dakota, where people have to travel many hours with limited access to transportation, to be able to speak to providers before making long treks, only to realize you've just spent an entire day and then sent home with no resolution to to whatever your particular health issue is at the time. And then also to promote an annual health summit of all the different types of providers, including Indian Health Service, other private providers in and around the reservation, to increase collaboration amongst those groups. So the Tasina Luta was initially developed by Margaret Bad-Warrior, who is a key collaborator on this project, or has been, and it was signed off on as a new initiative by the Cheyenne River Sioux Tribal Health Council, for which Margaret Bad-Warrior was also the legal counsel at the time. She also has a public health background in addition to her legal background. Tribal Health asked Texas A&M and our research team to help facilitate the first annual health summit in 2017. That's one of those 4 pillars. After A&M researchers, particularly Kay Carpenter, who will be the commentator today, had been working with the Cheyenne River Sioux Tribe on public health and emergency preparedness issues for approximately 12 years. And as many folks know, especially with vulnerable populations, having a real strong personal relationship, and one that has been built up over time, is essential to be able to try to conduct research projects and community-based participatory research effectively. And luckily, we, members of our team, have many, many years of experience working together on a variety of projects, primarily in the public health and emergency preparedness arena. And then the Tasina Luta project was much more of a public health focused than some of the prior work. Okay, so where are we talking about and what's part of the challenge here? Many of you have probably seen a map like this, which is just showing life expectancy at birth for both sexes in 2014. And the United States has a very wide range where some counties, and this is at the county level, all the little, the darker colors you can see in places like Boulder, Colorado, and the Bay Area, where people are living over 80 years, have life expectancies of 80 plus years. And we also have places that are in the 60s, a 20-year spread, which is quite astounding. But of course, within country disparities are something that we all should think about more and have been thinking about more, particularly in the public health field. And where are we talking about in particular? We are talking about central South Dakota, where you see some of those, stronger red outlines or fills. And we're actually talking about the two counties that are sort of in the central to the west. That's Dewey and Ziebach counties. That's the Cheyenne River Sioux Tribe Reservation. You'll notice that there are some other counties that have even lower life expectancy, but the metrics aren't particularly great for Dewey or Ziebach either. And we'll look at some of those metrics. This is from the county health rankings from 2019. And the two counties that we've been working with are the Dewey County and Ziebach County, which are in bold there. And at the bottom of this chart, you can also see that we have the South Dakota averages and US averages for comparison, also in bold. Dewey County, which has a slightly higher median household income, is where the main administrative center of the Cheyenne River Sioux Tribe is located. Yet it has higher unemployment, lower life expectancy, similar food insecurity, slightly fewer people than Ziebach County, rating their health as poor or fair, pretty high levels of diabetes, similar between the two counties, but much higher than the South Dakota or US average, higher levels of obesity, although in Ziebach you see even more, high levels of high smoking rates, and actually slightly lower excessive drinking rates than you'll see, at least in comparison to the South Dakota average, and then similar to the US average. Now, clearly, what stands out here is also that median household income is much, much lower than you see across the state of South Dakota and also across the United States. So we're talking about very rural areas. There are high rates of unemployment, poor health outcomes, low levels of life expectancy, and actually some difference between the more rural county to the west and the more populated county to the east, which is where the administrative center is, but it's also where you find more of the issues relating to substance use and some unemployment. Okay, overall, the Cheyenne River Sioux Tribe has a population of approximately 8,000 people, but it's only slightly smaller land area than Connecticut. And Eagle Butte, which is right there in the middle, has approximately 1,350 of those 8,000 people. So it is a very, very rural part of South Dakota. In terms of access to healthcare services, there is actually an IHS hospital right in the middle of Eagle Butte. It is relatively new. The facility is actually quite nice. There is also a tribal health division that is part of the tribal authority. They have some clinics and they do a fair amount of outreach. They also have community health representatives that serve as community health workers assigned to the various regions around the reservation. There are some, not too many, but some private providers that work around Eagle Butte or in other parts nearby the reservation. And then larger hospitals are located a few hours away in Rapid City, in Pierre, South Dakota, or Bismarck, North Dakota. So what was our research focus? So our task, the A&M and CRST research team, our task was to gather information from local experts and tribe members regarding strategies for the implementation of the CRST's first locally driven public health plan. This is something that the tribe had not done before. So we utilized a CBPR model where community members would provide guidance for how this plan should initially be implemented. How could we get people to want to engage? And so we went out and we asked community members and some local sort of key leaders and key stakeholders about how they thought this should be rolled out. So we're basically gathering market research and information for how could implementation be better pushed forward for this new initiative. So what did we do? We conducted approximately 14 key stakeholder interviews, about 1 hour each, with community leaders and public health professionals, and covered a lot of topics, including critical success factors for program implementation, what would be the best sort of outreach strategies, how would these different stakeholders prioritize implementation efforts in terms of which of the 4 pillars would they want to start first with and why, and other ways that they would use to encourage individuals to engage with the program. Now, we also conducted 5 focus groups, 4 with community members, 1 with community health representatives that worked, the CHRs that work for tribal health in Eagle Butte. And we covered a lot of the same issues, and it had a few additional questions on things like why and when people chose to access medical care and other barriers that people commonly encountered when they were considering accessing care. Okay, we conducted those focus groups in the highlighted locations there around the reservation. We had the 2 in Eagle Butte because one of those was with the community health representatives and another was with community members. Eagle Butte is the largest town on the reservation. Dupree is also a somewhat sizable town. And then we also went to 2 very small rural towns, Whitehorse and Bridger. Of course, all of these locations have less than 2,000 people living in them, but in Bridger, there may have only been 24 houses in that community, so it's very small. And this table should give an idea of who participated in each of these focus groups. You can see that the vast majority of participants are folks who lived on the reservation. There was 1 person from the state who did not, and 1 other that I can't remember off the top of my head. But we also asked each of these individuals sort of what their prioritization would be for in terms of which of the 4 pillars they would start with. And on this left side, where we're speaking more to community members and the community health representatives, you can see that the votes fell heavily in getting people to go to annual health reviews or the 24-hour Ask a Nurse hotline, whereas the sort of key stakeholders, community leaders, many of whom were health professionals, really favored the annual health summit as a necessary initial step to get engagement across the providers in and around the reservation, to get them to work together first before actually trying to push this program forward. Now, in the focus groups of community residents, not for the community health workers, we also asked people a little bit about their health-seeking behavior. And these were all done during sort of the interview time. This was not an additional survey that we conducted, but just sort of a question and answer session within the focus groups themselves. You can see that about half visited a healthcare provider during the last year. And then you can see the breakdown there of where people actually visited health providers, most of whom went to the Indian Health Service Hospital right there in Eagle Butte, some who went to tribal health, and smaller numbers going to private clinics or making use of traditional or spiritual medicine. That number of approximately half of people seeing a healthcare provider in the last year is much lower than the US average of about 84% of individuals see a healthcare provider during any given year, is the most recent metric that I was able to find. So people are clearly accessing health care a lot less on this reservation than they do elsewhere in the United States. And even smaller numbers, around 20% or perhaps less, actually had a physical or an annual health review in the last year. So what are some of the themes that came up in our focus groups? One of the themes that came up over and over again very strongly was this notion of, yes, people are not accessing care, and sometimes when they do access care, it's really too late. So here are a couple quotes that I'll just read through. Where I work there are lots that disregard their health, even if there's an existing or pre-existing medical condition, and they cover it up with alcohol and drugs. So by the time they do decide to sober up, it's already in bad stage. We don't get them here until, like I said, middle 3/4 or end stage of sclerosis. We have a huge no-show rate on just our diabetics that need to come every 3 months, at our cardiac patients that come every 6 months to a year, depending on what they're there for their EKG or whatever. It is not easy to get people to their appointments. And recall that there's also very high rates of obesity in both counties on the reservation. So there's a lot of diabetes. A lot of our respondents also discussed the challenge of different health systems not necessarily communicating with one another. There's at times been a division in providing healthcare between our private sector, tribal, and IHS, and it's widely known that this happens. Some people just refuse to come to even tribal health or IHS. They want to go to private providers because something happened here that they didn't like, and we don't have consistent providers at IHS. Many of you who, if you have done work with IHS, it is hard to recruit providers to very rural locations where many of these reservations are. And turnover is definitely an issue, and it's something that concerns a lot of the tribe members. In our discussions about, okay, so we know that there are these problems and that they exist, but we also want to ask individuals, stakeholders, and community member focus groups in each of these settings, okay, so what do you do? We talked about a variety of different types of communication methods and promotion methods, which of course, on a very rural reservation, there are some additional challenges when not everybody has access to electricity. There are some issues with having access to cell service. Not everybody can afford to have a phone. But one of the things that came up frequently that people made recommendation was provide people with some kind of incentive. Much like I have from my personal health insurance plan, if I get an annual health review or a physical once a year, there is a reduction on my deductible. I have some incentive to go and see a doctor once a year through my health insurance. And this was something that we also heard very frequently across the reservation. To get them there, or sometimes to get people to participate, you may have to offer an incentive. I hate to say we are incentive driven, but it is what may make a difference between somebody participating and somebody not participating. I look at it in two different ways. One, that we are incentive driven, but we are also trying to survive. And recall the median income levels in those counties are at about half of what you see across the United States. So there is a lot. There's endemic poverty. There's high levels of unemployment. There are high rates of diabetes, high levels of obesity. It's incredibly rural with limited access to transportation or oftentimes limited financial resources to be able to afford gas. If you don't have a car and you want to get a ride from a friend or neighbor, then sometimes you might want to contribute some financial resources to pay for the gas, but that's also not always feasible. And so the next quote is, we kind of got into this rut where you have to either offer food or incentives. I probably shouldn't say a rut, but it seems like when we do have functions and we don't offer that, we are not getting as good a turnout. And then maybe, you know, with our addictions and people on a fixed income coming to eat, it's also true that in the Lakota culture alone, if you feed them, that's an honor. And at each of our focus groups, we also did provide meals. It is a tradition at gatherings on the reservation where food is provided, and it is seen as an honor, and it's one of the hopefully culturally appropriate mechanisms through which we were able to get people to participate in this project and share their valuable information with us. I think this is the last theme, or maybe there's one more that hopefully Kay will talk about a little bit in our commentary period here as well, that persistence matters on the reservation, and it has a bad track record. The quote is, we have to be consistent because one of the biggest complaints is that we try to introduce something and then it never follows through. And this is a huge challenge, especially, and you know, we have a lot of hope for initiatives like the Tasina Luta, which is locally driven and locally developed. And then at the same, and hopefully that would also make it more sustainable over time, but politics matter locally, and things happen over time. Okay, I think this might be one more theme after this. Medicaid is very important for a lot of folks on the reservation, especially those that live in the sort of further west, very rural part of the reservation. Note that South Dakota is a non-expansion state, but many of the individuals on the reservation can qualify for Medicaid because incomes are so very low. And those who lived in that sort of smallest community that we did our focus group in the southwest part of the reservation, they won't necessarily go to Eagle Butte, to the IHS hospital for their care, because it's actually equidistant, not as the crow flies, but as the roads go. It's equidistant potentially for them to go to a larger hospital in Rapid City, further to the west, or they might go to a smaller clinic in a town called Phillip, just a little bit to the west, rather than having to go all the way into the IHS hospital in Eagle Butte, and according to many of our respondents, potentially have to wait in long lines. But then again, those that don't have Medicaid, who, even though it's easier to go to places like Phillip or Rapid City as opposed to Eagle Butte, if they didn't have Medicaid and were hopeful that IHS would reimburse them for their care retroactively, sometimes that did happen, but sometimes it doesn't. And there was a lot of concern about what IHS would reimburse for. And the problem is when you're already sort of accessing care, there are a lot of question marks about your health. Having the additional question mark of, will I actually be reimbursed for this, or I'm going to get hit with a huge bill, is another one that we would hope nobody would have to deal with, but we see that even outside of reservations quite frequently as well. Okay, transportation clearly in this very rural area is a key challenge. And one of the other recommendations that became apparent, and there are some tribal health clinics out in some of the more rural communities, is that it may be necessary to go to people. Especially for engaging people with preventative care, getting them to travel long distances with limited access to transportation, which is also a financial burden in addition to the time burden and the other opportunity cost burdens. we really will have to get folks out into the communities to make this done. And of course, logically, targeting those that are already engaged with their healthcare will be easier, but getting others, especially those who have maybe graduated from high school, perhaps they are unemployed, getting the middle-aged folks to want to engage when they haven't for so many years is going to be very, very difficult. Social media is widely used among youth and the working class who have connectivity, but again, connectivity is very limited for those, especially in the most rural areas. Okay, and with that, thank you, and I think we'll go to Kay for, did I go too far? I no longer see that screen up there, but I think it's time for Kay and her commentary.
Thanks, Dave. As Dave mentioned, I've been one of those who have been working in Indian country in South Dakota for over a decade. Most of my work has been primarily focused on public health emergency preparedness issues. So this project was exciting because it allowed me to broaden my reach within the community and to learn about public health issues that are impacting the people of, in this case, particularly Cheyenne River, on a daily basis. Working in a tribal community is really a privilege, but there are unique challenges that have to be addressed. Tribes are made up of one or more extended families that have banded together for any number of reasons over the past 100 years. These family ties are strong, and the local politics are often interwoven into these familial relationships. In addition, the tribal leadership changes frequently as elections in many of these Great Plains tribes occur biennially. With new leadership, the priorities change, as well as the staffing for key appointed positions. These new relationships between the tribe and the research staff then have to often be renegotiated. And as Dave mentioned, these challenges also affect the ability for any particular administration to carry through on programs that have been promised or have been advertised within the community. Hence the feeling among the focus groups that persistence matters and that things are often not followed through. During the past year, we've witnessed several of these staffing changes. And although there have been some challenges, there have been also some new possibilities created. For example, the author of the Tasina Luta, although she is still affiliated with the Cheyenne River Sioux, has now moved into a position as tribal counsel for the Great Plains Tribal Chairman's Health Board, located in Rapid City. This board is a consortium of 18 tribes across 4 states, and through her position may allow us an opportunity for broader discourse to extend the implementation of the Tasina Luta across multiple tribes. As Dave mentioned, one of this study's findings was the self-perceived importance of incentives to motivate the tribe to get wellness exams. A logical next step for us would be to look at the role of incentives, how much, what type, etc. However, local politics and the closeness of the community made it unfeasible in this first round to provide an incentive to some, but not to others. Now, with potential access to multiple tribes throughout the Great Plains, staging trials across different tribes may allow for further research on how incentives could impact the implementation of this pillar of the Tasina Luta. We're excited about this possibility, and we look forward to any opportunities that may arise that would afford us an opportunity to continue our work. Thank you.
Thank you for sharing with us. We don't have any questions yet, but I definitely suggest folks who have any burning questions to add that to our Q&A box. But in the meantime, I do have a question. And I guess this is directed towards Kay, but definitely take a response from either or both of you. But it was interesting, Kay, you mentioned that there's so much dynamic movement within the tribe in tribal communities in terms of changes in leadership and having to renegotiate relationships with researchers and so forth. But considering the historic context of tribal communities in the United States and some of the deep injustices that have been experienced, what are your thoughts on ways to create trust within these communities that you're going into, considering that historical context? And I guess a second part to the question is, there's a lot of deficiencies to be found in the healthcare system and in tribal communities, but how do you think about assets and identifying those assets in community and incorporating that into your work and the way that you engage with them?
Sure. I think, and this is really taking a broader view from my years of experience, not just the Tasina Luta, but working with communities on the public health emergency preparedness issues. The biggest thing is the building of trust, and that doesn't come overnight. And so you can't just go in and take and not give back, and you can't go in and not come back. I mean, in a decade or more of working with the tribes, it's still a challenge. I have better relationships with some than others, but it always comes back to, I know Kay's going to come back. I know that what she promises to deliver, she will deliver. My motto always is to under-promise and over-deliver, so I don't disappoint. And that sort of leads into the resource piece. Obviously, there are huge challenges, and when you go into a community like I do and talk about emergency preparedness, for a lot of these communities, every day is emergency preparedness. And so my strategy anyway is to allow the community to drive that discussion and to try to help prioritize what's important to them. When you work in other communities, sometimes you can guide that discussion differently. But I think when you're working in a population such as the tribal populations, it's important to make sure that they have a voice and that you listen to what they feel their priorities are, and also to encourage them to look into their communities for their strengths. Sometimes we think that vulnerable populations don't have strengths, and truly they do. I mean, they do have a sense of community. They do care about one another, and they tend to look at a problem as a problem for the whole community, not just their own. And so those things can be used to the tribe's advantage. You just have to recognize that.
That's a great response. Thank you. We did get one question from the audience, Elsie Moore. Would like to know, are tribe members with health issues open to having their caregivers involved with their care? And if not, do you have any recommendations on how to address that with patient or the caregiver?
So
that's directed to either.
Some are more open than others, of course. There are tribe members who are being seen for their chronic care issues that have built up relationships with their providers. But then again, you know, with high turnover rates too, those providers can change. And one of the big challenges is there's such a large percentage of the population that is not engaging with existing healthcare services. Oftentimes because of, you know, there's some kind of historic distrust there, or there were issues that happened beforehand that people feel like it's not helpful to go to the provider. So, I mean, this is sort of the crux of the issue, is how do you convince those that historically have not engaged, or perhaps they did and then for very valid reasons have chosen to disengage until sort of crisis moments arise. How do you get that sort of harder portion of the vulnerable population to really want to be involved? And I like that you pointed out that there's a provider side to this too. It's not just about turnover. It's also, of course, about cultural sensitivity and cultural awareness. And the providers in many of the IHS hospitals are not Native Americans, or perhaps they're from different countries. You know, I have not attended a cultural awareness training within the IHS. I'm sure that there are efforts made in those directions, but of course, that is one strategy that's hopefully being employed. And to get the patients, I mean, efforts to get patients more engaged or being more open with their providers in a longer term conversation where there's continuity of care, you know, the first step is to get them in the door and to simultaneously also produce a positive result and have a positive experience for those patients. So there has to be work done on both sides. It can't just be getting patients in the door, but it's also, I think it's important, as you highlighted, that there are trainings for providers to make sure that patients would want to keep coming back. And what we've focused on so far is sort of getting them to the door in the first place, is what a lot of the sort of discussion around incentives has been, because that has been a huge challenge. Thank you for that question.
Awesome response. And we have a question from Samantha Steinmetz. Samantha would like to know if your research, in any of your research focus any of your research focused on access to mental health care on the reservation, and they'd like to know if so, you know, send or post an email address for follow-up questions.
So we didn't focus on mental health care specifically. However, it came up in almost every single one of our focus groups or conversations. Some of our respondents included individuals who work with behavioral health for the tribe, you know, they had some very interesting quotes to share with us and some great insights. But that wasn't a key focus of this particular project. Although I think it would be a great follow-up work to be done. There's a huge need for mental health care professionals on the reservation. There are very few of them. In terms of options, there really aren't that many. So there's, you know, but there are also, in terms of the strengths within the community, family and caregivers and grandparents taking care of their grandchildren, and there are strong social ties across the reservation that also can help as people support one another. And in fact, in some of the smaller rural communities, you know, they talk in some cases about going, Eagle Butte's the dangerous place. That's where you see more of substance use, and you see sort of more homelessness. And in these smaller communities actually provide incredibly strong safety nets where neighbors look out for one another. And in many of these rural communities, you'll find pockets of 20 to 40 houses, but they're all very proximately located. And there actually is a very strong sense of taking care of your neighbor, who also might be a family member. So there are support networks. There are not enough mental health professionals. Wasn't a focus of our research for this particular project, but it was an issue that we certainly heard about frequently.
And David, I have a question about transportation. You mentioned that as an issue within this sparsely populated landmass with not a lot of people. Definitely makes sense for transportation to be an issue, given that there is such that sense of community and that sense of like supporting your neighbors. Have you come across any examples of community support in transportation, maybe not-for-profit engagement, helping to organize taking neighbors to appointments and things like that? And do you think that that would be helpful in that space?
So absolutely, it would be helpful. In terms of not-for-profit engagement, I didn't see a whole lot of that on the transportation side. But yes, we heard many stories of neighbors helping out their neighbors with transportation, and often there's a sharing agreement where you might also help to cover some of the costs. There is a public transportation service on the reservation now, but it costs, because of the great distances, it costs several dollars per trip, which is something that's just not affordable for a lot of tribe members. But and I think the neighbor helping neighbor model is actually probably the most frequently used model for transporting across larger distances on the reservation. For some period of time, the community health workers or the community health representatives that are all assigned to different regions, part of their job in some cases is also to help provide necessary transportation, especially for the most vulnerable or elderly reservationists. But there's been some back and forth about, or there was some back and forth about the appropriateness of that, because it is very expensive for tribal health to maintain that when distances are so great. And there were also questions about, is that really the role of a community health representative, to be a transporter solely? And then, on the other hand, it is a huge benefit for folks that are otherwise living in very isolated communities where buses do not pass by. If there were potentially ways of facilitating the intercommunity helping of neighbors and family members, potentially with reimbursement type models. In terms of making use of existing strengths and infrastructure, I think that would be a model worth pursuing. But then, of course, administrating something like that across a very rural network could prove challenging. But that's, the neighbor helping neighbor really does seem to be the model that's most often used, because in many cases there are limited other options.
Thank you for a response. We have one additional question, and I guess we'll wrap here. Was there any follow-up after linkage to healthcare? And if so, did they continue to have care? And were there any additional barriers identified in continuing that care?
So yeah, follow-up is certainly an issue, especially when distances are so great. So transportation is a key issue. The additional barriers could also include communication. Not everybody has access to cell service or to landlines. So appointments get missed frequently as well at IHS. You know, the other barrier that I mentioned earlier about turnover, I think, is a barrier to follow up. I think access to financial resources, whether it be in terms of just, you know, paying for transportation to come and get medication, or trying to acquire medication somewhere closer to where you live. All of those things are barriers to follow up. Sort of the, you know, and the confluence of all of these different barriers, sort of as people talk about in intersectionality theory, it's not just one barrier plus one barrier equals two barriers. It's that these barriers make the other barriers worse, so that 1 plus 1 might equal 4. Or 5, depending on the severity of the barrier and how much they intersect with the others, or how much effect modification there might be between, you know, transportation and financial resources, as an easy example. And I think particularly in highly vulnerable populations where we think about really low median income, high rates of diabetes, high levels of rurality, the multiplicative effect becomes very strong very quickly. And that doesn't just have an influence on people initially accessing care, but it also has an influence on people following up with their care. And we don't have data for this, but I think it would be interesting to see what that differential impact is of different social determinants on either initial access versus follow-up for those individuals. And I wouldn't necessarily want to hypothesize how those relationships might differ without having done some additional research on that. But I think it's a really interesting question.
Awesome, and I know I said that was the last question. Apparently I lied. Hallie Riggs does have an additional question. So Simply Smiles, which is a not-for-profit in La Plante, on the CRST, is creating a first-of-its-kind village, Native foster parents to care for vulnerable children on the reservation. This model connects to what's being said about neighbors helping neighbors, a true village of helpers. Any suggestions on how to recruit such adult tribal members?
Wow, yeah, so I mean, that's I don't know if Kay, you have additional ideas on this. So La Plante is actually not too far from Eagle Butte. It's a little bit further to the east. It's, at one point we were talking about doing a focus group there as well, but I mean, recruiting adult members can be difficult. It depends on, so the part of the adult workforce that have stable and steady jobs, which is only a part of the adult workforce, it may have time constraints, right? Because they're working 8 to 5 or potentially longer hours or whatever. And then there are parts of sort of the middle-aged population that have become less engaged through sort of historical distrust and other challenges that they may face in their experience. And recruiting from that group is similarly difficult as getting that group to also access care or stay continuously involved with their care. Now, the elder population, which is also highly revered and respected, may be an opportunity that may have slightly more time. Of course, many elders on the reservation are also taking care of their grandchildren, which is a time commitment. But maybe that could be a starting place where also those elders with their high levels of respect that they hold through the communities could potentially also serve as recruiters or as sort of agents of trying to get other people engaged that might otherwise be able to help. Kay, was there anything else that you wanted to chime in about recruiting adults?
No, I really like the idea of trying to engage the elders. They're respected in the community, and they are concerned about their community just because that's the culture anyway. Obviously, right now it's hard to engage people face to face, but the elders do meet for meals provided and that sort of thing, and there might be some opportunity to once we're past the coronavirus, to use those meeting times to give a pitch to engage the elders. There's also, the telephone teepee. If you can find someone in the community that has some leadership ability to begin to call people and that are in their circle. The good thing about a small community is just about everybody knows everybody, or they're related to somebody, and so to be able to use that circle as a strength seems like a good one to me.
Yeah, and I like the idea of the local community strength leading this. I was also thinking that maybe the community health representatives could also help in terms of partnering and engaging. But there are only, there's a small number of community health representatives for a lot of geography. And not all of them are able to know their communities that they work with as well as they would like. I think building from within the community is a much better approach, but you could also look at who is the community health representative that's assigned to La Plante, and if they had any ideas, because they also do a lot of outreach. And Kay's comment about providing a meal to get people together outside of coronavirus, of course, that is a very traditional and culturally appropriate method that people appreciate. People appreciate coming together and sharing meals together, and potentially then also learning about the program.
Thank you for those responses and great questions from our audience. If there aren't any additional questions, I'd like to thank our presenters today for engaging us in such a thoughtful presentation, and really thankful for the engagement that you did with listening to Luta, and we look forward to hearing more from you moving on in the future.
We hope so too. Thank you very much.
Thank you.
Awesome. So we have a few announcements as we wrap. Our upcoming webinars are April 1st and April 15th. April 1st, we'll be hearing from our Coordinating Research Center at Arizona State about financing and service delivery integration for mental illness and substance abuse. And on April 15th, we'll be hearing from our team at Johns Hopkins about optimizing governmental health and social spending interactions. So look forward to us following up with an email with the slides from this webinar, and also check out our website at systemsforaction.org, where we'll also upload this entire webinar along the slides as well. Thank you so much for joining us, and we look forward to seeing you April 1st.